I would like to welcome you to our second session of the Oxygen Therapy and Critical Care, the case-based series on March 25th, 2021. So today we are going to be discussing on diagnosing hypoxemia and the use of pulse oximetry. Our panelists who are going to lead us this session for today, we have Dr. Al-Hassan Datti Mohammed, who is the director for this ECHO program from Aminu Kano Teaching Hospital. Also, our co-panelists for today, we have Dr. Irene Akideno. We also have Dr. Salim Abdullahi and Dr. Musa Suleiman, who are going to be our co-panelists. Next slide, sir. Also, we have a French interpretation available for anyone who is interested. You can use the interpretation button at the bottom of your screen, and then you can choose French. If you do not have the interpretation icon, then you may need a new version of Zoom for this to work. You can choose to mute the English part of the session or listen to both. Translation will be louder than the speaker. So our programming is based on the foundation of love and respect. Please respond kindly rather than react if you disagree with something. It is everyone's responsibility to keep this webinar a safe space. We will be using the chat function for question and answer at the bottom of the screen. Please send all your questions through the chat box and feel free to introduce yourself. Please turn on your video, position your webcam effectively to show your face if you're alone, or if you're in a group, position the camera to capture the whole group. If you have any IT issues, you can send a message through the chat to ECHO IT. And you can get the assistance. And also remember that the session is being recorded and your attendance is a consent to be recorded. Also be mindful of infection prevention and control, and try to limit your numbers if you're joining from one place, and practice physical distancing. Thank you so much, and I welcome you to the session today. I would like to welcome Dr. Datti to lead us through the session. And whenever you are ready, I can begin sharing the LRC. Welcome, Dr. Datti.
Thank you very much. I'd like to welcome all our esteemed participants and the core panelists to help us navigate through this important topic. This is session 2 of the series. Diagnosing hypoxemia and pulse oximetry. Can you share the screen? Let's just start. Okay, thank you.
Okay, can you see my screen?
Yeah, yes, I can see.
Okay.
Yeah. So, it is a case-based discussion where some practical scenario will be used to discuss the topic. So it's hypoxemia and pulse oximetry. Now, this is the case. 57-year-old man presents with chills, weakness, and dry cough. So, and scroll down. So this is so we want to use this case to understand how to use a pulse oximeter, especially during the COVID-19 pandemic, which we are still in. The start cases are going down here in Nigeria, but it is still very much around. Then we want to understand and recognize pulse oximeter latency. There is a delay in the interpretation of the signal that you get from the pulse oximetry. Then we want to select and rank oxygen delivery devices by the fraction or the oxygen concentration, so that we know how to use these devices appropriately for optimum. We want to use develop, which we can use to select the most appropriate oxygen delivery device available. We also want to use the Lightbox trial tool to titrate oxygen therapy flows. Either you escalate or you bring it down, because there is no need when you are using 2 liters per minute flow and you're getting a satisfactory saturation. There is no need to escalate it to 4 liters. You will be wasting oxygen. Then we also want to learn how to assess your facilities non-invasive oxygen delivery devices that you have in your facility, in your centers, and want to assess the types of oxygen supply of your facility, whether be it through cylinders, or you have a pipeline system, you have oxygen plant, or oxygen concentrators. Then we want to be able to interpret data obtained using pulse oximetry and understanding the limitations of the pulse oximetry and pulse oximeter. And want to be able to list the conditions that interfere with accurate pulse oximeter readings. This is very important. It's a very practical point. And want to also remind ourselves or learn how to clean and maintain pulse oximeter devices so that they are ready for use anytime. Okay, so these are the objectives that we hope to achieve. Now, this is the case. A 57-year-old male patient presenting with a 4-day history of chills, weakness, and cough. His wife, who happens to be a nurse, tested positive for SARS-CoV-2 3 days ago, that is COVID-19. His SpO2 saturation read 89% at home, because the wife has a pulse oximeter. So his wife sent him to the emergency department. In our own facilities here, emergency department means accident and emergency unit or department. So at the hospital, the patient was screened for COVID-19 risk factors. You know, we have the list which to help us triage patients COVID-19. And now is isolated from other patients and is wearing a face covering. So you and the nursing student are wearing PPE for contact, or droplet, or airborne precautions. The patient admits he is short of breath with moving and eating, but denies fever, shortness of breath at rest. So the shortness of breath comes when there is some physical activity, eating or walking around, but at rest he doesn't have the breathlessness. So there's also loss of taste. He didn't, he said he did not have loss of taste or smell. He states he has been less active and has been staying in bed. So vital signs taken were heart rate of 95 beats per minute, a blood pressure of 95/52 millimeters of mercury, and a respiratory rate of 24 beats per minute. SpO2, like we mentioned, just like it read at home, 89%. And temperature was 36.5 degrees Celsius. So you recognize right away that the patient is hypoxic, and started him on oxygen by nasal cannula, that is prongs, nasal prongs. at 5 liters per minute flow. His saturation initially improves to 97%. So these are the questions. This is one of the frequently asked questions. How is pulse oximetry used in the COVID-19 pandemic? You can type, we'll give you just 2 minutes to type the possible answers into the chat box, and we'll see how much we know. So let me see. No answers coming. I can't see anything in the chat box. Just type what you have been doing during this COVID-19 patient in terms of using pulse oximetry in the COVID-19 pandemic. Okay, let's proceed. Perhaps the next they will provide the answer here, and they'll help us mind. Okay, so there is an instructional video here. We should all watch and listen to it to remind us on how we use it as a tool to take decisions.
Kevin, I can share the video if that would be helpful.
So,
Sarah, please go forward and share the video. I think the network here is unstable.
all right.
Can you see my screen of the video?
Yes, we can.
This video shows the use of a pulse oximeter in the context of the COVID-19 pandemic. Severe COVID-19 primarily affects the lungs. Measuring oxygen saturation is essential for deciding when to use precious oxygen resources during the pandemic. A pulse oximeter is used to measure oxygen saturation and can help identify severely ill patients who should be hospitalized and receive oxygen therapy. Please note, available oxygen, flow rates, and administration practices will vary according to local protocols and resources. Make sure you know what kind of oxygen therapy is available in your institution, how it can be delivered, and what local guidelines are in place. Do you need to measure your patient's oxygen saturation? You will need to decide whether your patient should have their oxygen saturation measured. To decide, you will need to ask 5 questions. 1. Does your patient have a fever? 2. Does your patient have a cough or difficulty breathing? 3. Does your patient have an increased respiratory rate? 4. Does your patient have any emergency signs, such as obstructed or absent breathing, severe respiratory distress, central cyanosis, shock, coma, convulsions, or uncontrolled vomiting? 5. Is your patient being admitted as an inpatient? Fever. Any known fever over the last 14 days is an indication to measure oxygen saturation. Cough or difficulty breathing. Any cough, difficulty with breathing, or shortness of breath over the last 14 days is an indication to measure oxygen saturation. Difficulty breathing can be any abnormal breathing pattern, including but not limited to breathing too fast, too slow, too deep, noisy breathing, labored breathing, or any pain or discomfort associated with breathing. Increased respiratory rate. An increased respiratory rate is an indication to measure oxygen saturation. This is a little more complicated than the other reasons to measure saturation, as normal respiratory rate varies with age. Let's spend a little time here reminding ourselves of abnormally high respiratory rates in different age groups. In adults and children 16 years of age and older, a respiratory rate of 22 breaths per minute or more is abnormal. In children 5 to 15 years of age, a respiratory rate of 30 breaths per minute or more is abnormal. In younger children from 1 to 5 years of age, a respiratory rate of 40 breaths per minute or more is abnormal. In infants 2 to 11 months of age, a respiratory rate of 50 breaths per minute or more is abnormal. In neonates and very young infants up to 2 months of age, a respiratory rate of 60 breaths per minute or more is abnormal. Any patient who has an increased respiratory rate should have their oxygen saturation measured with a pulse oximeter. Emergency signs. Emergency signs are an immediate indication for admission and resuscitation, including administering oxygen therapy. Resuscitate, administer oxygen, and measure the patient's oxygen saturation if any of the following signs are present. Severe respiratory distress. Signs of severe respiratory distress can include obstructed or absent breathing, head nodding in younger children, nasal flaring, grunting, usually in younger children, tracheal tugging, intercostal retraction or inward pulling of the skin between the ribs during inspiration, and deep lower chest wall indrawing or inward pulling of the skin below the ribs during inspiration. Other emergency signs include poor perfusion or weak pulse, which is a sign of shock, coma, convulsions or seizures, or vomiting all food and drink and medicines. If your patient is being admitted to the hospital with suspected or confirmed COVID-19, or for any other respiratory illness, use a pulse oximeter to check oxygen saturation, along with vital signs. For patients who are under simple observation and do not have low oxygen levels, these should be checked at least every 6 to 12 hours, depending on illness severity.
Do you want to go through this whole video, Dr. Datti?
Yes.
Okay.
How to measure oxygen saturation. When using a pulse oximeter to measure oxygen saturation, remember to use the correct probe for your patient. Young children in particular need appropriately sized probes. It may be difficult to get a reading in critically sick patients. We recommend 2 strategies to make it easier to measure the oxygen saturation in younger children below 2 years of age. First, using the big toe, as this allows the child to sit comfortably in the caregiver's lap and be comforted. Second, you may allow a breastfeeding child to feed during the measurement to improve cooperation. You may have to wait 30 to 45 seconds for the pulse oximeter to display the pulse rate and oxygen saturation readings. If your patient is very unwell and you cannot get a reading, administer oxygen and call for help immediately. How to use the oxygen saturation to decide next steps. You have now used a pulse oximeter to measure the oxygen saturation of your patient. Depending on the result, you will decide to administer oxygen or plan how to monitor your patient without oxygen therapy. If the patient's oxygen saturation is 94% or higher, and they do not have any emergency signs, you do not need to administer oxygen at this point. In this case, you should follow local protocols for COVID-19 testing and isolation. Remember, all inpatients should have their oxygen saturation measured with their vital signs every 6 to 12 hours. If the oxygen saturation reading is less than 94%, or if there are emergency signs, administer oxygen via nasal prongs or standard oxygen face mask, and check the saturation every 2 to 5 minutes. The next oxygen therapy decision is made depending on the outcome of 15 minutes of oxygen therapy. After 15 minutes of oxygen therapy, check the oxygen saturation again with your pulse oximeter and check whether the reading is 90% or above or less than 90%. If the oxygen saturation is 90% or above, continue standard oxygen therapy as you are doing and monitor the patient. If oxygen saturations rise to 96% or higher, reduce the oxygen flow rate. Oxygen saturation and vital signs should be measured at least every 4 to 6 hours while oxygen therapy is ongoing. If the oxygen saturation is less than 90%, oxygen support should be maximized. Oxygen flow should be increased where possible. Other measures include using a face mask with an oxygen reservoir for adults and a head hood for infants. Once again, oxygen saturation should be checked every 2 to 5 minutes. Check oxygen saturation using a pulse oximeter after 15 minutes of maximal low-flow oxygen therapy. If the oxygen saturation is 90% or above, continue maximal oxygen therapy and monitor the patient. Oxygen saturation and vital signs should be measured at least every 4 to 6 hours while oxygen therapy is ongoing. Oxygen saturation should be maintained between 90 and 96%. If the oxygen saturation is less than 90% on maximal oxygen therapy, refer for ICU admission where available and escalate respiratory support where possible. Oxygen saturation should ideally be monitored continuously. Oxygen saturation measurement is the best tool you have to decide when to use and maximize precious oxygen resources during the COVID-19 pandemic. We thank you for all that you are doing for your patients during these difficult times.
Okay, thank you very much. So we've seen from the video how to use the pulse oximeter and then the results you obtain and when to escalate. We'll move on. So, how long after starting oxygen should the SpO2 increase? You can type in the chat box. We'll give you 1 minute. How long after starting oxygen should the SpO2 increase? Within the video has given you some of the answers, so you should be able to remember. Type in the chat box. You say 4 to 5 hours. The hours or minutes? "30 minutes to 1 hour. 2 to 15 minutes. 3 to 5 minutes. Every 2 to 5 minutes. 5 to 10 minutes. 3 to 5 every 15 minutes. Okay. Some of the answers are way off. They might, I think, so. Let's click to see what we have there, so we can compare with our answers. Okay, so on the This is where you can have the results. You can see in pulse oximetry, you can learn all about it at your spare time. You read. It gives you, there is an introduction where it tells you what is pulse oximetry, what is it all about, and then how it works. For the resident doctors going for exam, especially membership part 1, this will be asked, and even questions on the COVID-19 pandemic will be asked. We did that last exam, so I expect this kind of thing. And the accuracy, and that's where you will see all the how long it takes for you to get the response and so on. So this is a great article that you can get. So, and this is a graph that you can see everything lowness and then what affects the pulse oximeter, the waveform. When you have normal signal, low perfusion, this is what you get, a flat curve. And when you have noise as an artifact, this is what you get. And then when there's motion, patient moves the hand and so on. So you got to stabilize the hand to get the normal signal. And then only then that your reading will be accurate. Because if you use the wrong reading to take further action, you may harm the patient. Okay. So let's get back to the okay. Let me call on Irene. If you're around, you can take this next steps, next stage of the discussion, rank these oxygen delivery devices in order from the saturated, concentration delivered to highest FiO2 delivered. Irene? Hello, Irene. Okay, what about Dr. Salim?
Okay, thank you. Then Dr. Irene has dropped a message that she cannot unmute.
Oh, okay.
Yeah.
So you carry on while that is sorted out. Okay. So
okay. All right, thank you. So from the question says, rank these oxygen delivery devices in order from least FiO2 delivered to highest FiO2 delivered. The devices are, we have the Fexmax as number 1. Then the next picture is the Venturi device. Then the nasal prongs as number 3. And then number 4 is Fexmax with a reservoir bag. So participants, let's see your response on the chat box. Rank them in order of the highest FiO2 delivered. Yes, answers are coming. 3, 1, 2, 4. Three, 1, 2, 4. The answers are coming. So basically, most of the participants, they responded with 3, 1, 2, 4. So going back to the question. Yes, can we go back to the question? Okay, so number 1 is simple face mask, 2 is Venturi device, 3 is nasal prongs, and then the fourth one is the face mask with the reservoir back. And then the question is to rank from the least FiO2 delivered to the highest. So let's click on the answer and then we compare with the responses we got from the participants. Okay. Okay. So the least delivered oxygen delivery device is the nasal prongs. Because with the nasal prongs, you only achieve FiO2 of 24 to 40%. So it's the least delivered FiO2. And then this is followed by the face mask. So the simple face mask, because the highest FiO2 delivered with the face mask is up to 45%. Then the next on the rank is the Venturi device, which delivers an FiO2 of up to 60. The Venturi device. Okay, the Venturi device deliver FiO2 of up to 60%. When the face mask and the reservoir back, you get an FiO2 of between 60 to 95%. So the correct answer is yes, the list is nasal prongs, then followed by the Venturi device, then the simple face masks, then oxygen with the face masks with the reservoir back. Thank you.
So thank you very much, Dr. Salim. Sorry, Irene, I think they are trying to fix your IT problem. Now, let me throw more light on these devices. They are very important. This is the devices that you are likely to have all or some of them. If we go to each of the devices, what they can deliver, the next thing, the details on the device, yes. So remember, in one of the practice changes, what we want to achieve, the objective is we know oxygen is very scarce. Where it is available, it's expensive. Supply can be epileptic. So it is good that we should use it judiciously. And these devices will help us do that. Now, for a patient like this one that is conscious and so on, you want to choose the nasal prongs because of this property, I mean, the features it has. You can use the flow of 0.5 to 5 liters maximum per minute. And the fraction now, the FiO2 means fractional inspired oxygen concentration, which is it's from 0.1 to 1. 1.0 means 100%. So it gives you 28% to 40%. And because we are all breathing 21% oxygen from the air we breathe in, so if you're giving oxygen therapy through this device, you're going to get 28% to 40%. And then you check your pulse oximeter, the reading, to see, are you getting the desired, you set your objective that you want the saturation to be at least 95% or above. And if you're achieving that, there's no need to escalate the flow from 2 liters per minute to 5, even with this one. That is the practice change. Then with the nasopharyngeal catheter, this is more appropriate for a child, and similar thing, you have the FiO2, you are getting slightly higher, 45% to 60% in the flow of 0.5 to 2 liters. Now, note the change. It's not 0.5 to 5 liters. So the maximum flow you can use with this catheter, I mean, the device is 2 liters. If you are not achieving the desired objective or the saturation, satisfactory saturation, after 2 liters, then you need to change a device that can give you that. Then the next one is the face mask, which can be used for both adult and child, depending on the situation. And this is more appropriate when the patient is, there is mouth breathing, or like the nasal cannula, the patient has to be conscious and there's no mouth breathing. But this one you can use both, I mean, when there is mouth breathing. And then you can see the flow is 6, slightly higher. You start from 6 liters to 10 liters. That's when you're going to achieve, you'll be giving about 44% minimum to 60% of the oxygen you are adding to the air the patient is breathing. And you can see why you need to choose the appropriate device so that you can save on oxygen. So you don't need to start this one because it's on the higher flow. And then when you can now get at 2 liters per minute, you can get the satisfactory saturation. Now, the only way to get it is your pulse oximeter when you use it appropriately. So these are some of the things. Now, the mask with the reservoir bag you can use for both adult and child, and you can see the flow keeps going higher. It's 10 to 15 liters per minute, and you can get from between 60% up to 95%, because the reservoir bag concentrates the oxygen, and then you end up getting up to 95% of the oxygen. This is very effective, but then you have to choose the situation correctly when you need this. That is when all these other ones, you're not achieving much with those ones, then you need to escalate to this. Then you have the Venturi mask, which is variable. For those of the participants that have this, the set is color-coded and is written. When you're using this color, this is what you're going to get. And the flow usually is between 4 to 15 liters per minute. And you will be getting between 24% and 60%. And this is good for patients that are dependent on the hypoxic drive, for example, COPD patients. You need to titrate the oxygen therapy. We don't give them very high oxygen therapy. We don't want to knock off the hypoxic drive. Okay. So let's get back to the. So I don't know if Irene are you able to unmute?
Yes. Hello, I'm
Okay.
back.
Okay. So, so you can take this frequently asked question and the next case update.
Okay, then. Thank you
Yeah,
very much, Dr. Datti.
thank you.
I'm back. The next is, when do you need to escalate oxygen therapy support? I think we can briefly also answer if we have, because as healthcare providers, we are there in the unit, we've attached the pulse oximeter. And when do we think we need to increase the flow rate or change the device? Can we just have a minute to see? This is just what we do every day, just to share with others. When do you need to escalate your oxygen therapy? As the ICU nurse or the doctor there, what would make you decide you need to either change the device or increase the flow rate? Is it possible to type in your answer in the chat box, Zainab, so we can get more answers since we have just 1 minute? Thank you. Should we go ahead? Or are people still typing? Okay, we have one answer. When the SpO2 is not up to 90 to 95%. Thank you, Josephine. When the patient is noticed to desaturate, no improvement, yes, after a minute, 60 to 120 minutes, after an hour. Thank you for your responses. So can we click, can I see, okay, when SpO2 is 90 to 94, when there's acute respiratory distress. Thank you. When SpO2 is not improving as expected. Thank you very much. Very wonderful and practical answers. This is what we do on virtually a daily basis. These are observations that affect our decisions. Can we click, I don't know, to continue? We've gone through this slide before. Okay, we can go back. Okay, the slide that should show is a slide that has shown, I think it was the initial slide we watched to the end, the YouTube video, if I'm correct.
Yeah, this is the
Yeah,
one.
the answers
Yes.
are there at the video is going. I asked you to just continue so that we don't go back, just to give them a head
Yes.
start. Yeah, but
Okay.
the go by is there when to escalate in the video.
Yeah.
Yeah.
Okay. So should we play the video or should we continue because of time?
If we can play that part, that is good since we still have time. I mean, not all, but that part where they can see when to escalate oxygen therapy, if it is possible.
Okay.
Sarah, can you share the video?
Yes. Give me 1 moment. You want me to play how much of this video?
Is there a portion that shows when to escalate oxygen therapy? Can we get it? Is it possible, or?
Yes, it's here.
Because we had played all of this before. Sarah, it's okay if we go back. We've watched it, and I think I can have a recap.
In saturation.
So do you want me to?
Yes, yes. I don't think it's necessary, so we can.
Oh,
Okay.
okay.
That video was the one initially, and it's available on the learning resource site. We had played it before. It would be quite difficult to get, but usually in our clinical practice, and based on the previous question on the devices and the flow, the FiO2s are achievable, and based on the responses on when do you escalate. First of all, the pulse oximeter is there to tell us how much oxygenation the patient is at that point in time, and we want a saturation above 94. So if you're starting with nasal prongs, you've gotten to the maximum of 5 liters, and your saturation is not increasing, then the next thing is you need to move to the next stage, and that is where you use the simple face mask. We've looked at the previous slide. We know the maximum flow rate you should get, and the maximum FiO2 gives us about 60%. If you're not getting that, we move to the next one, which is the non-rebreather. So understanding how much saturation you can achieve, how much FiO2 you can achieve with the devices above will help you know what to do. So you have your pulse oximeter giving you the values, and you know your desired value is above 94. Now you have your devices, which you should understand, and which we all from our interaction understand now. And then we can better adjust and know now, no, I need to move to plan B. Then I need to go to the next one and the fourth one. For institutions who have the HAFO device, which are those Venturi cones, then of course with those you can decide to give up to 60%. But remember, if with that you're not getting FiO2s above 94, then the non-rebreathing bag is now your last resort before more definitive airway management. Okay, I think I can move on, or except there are questions as regards when do you need to escalate. Well, of course, if patient becomes clinically, you have patient starts becoming unconscious, altered sensorium, you know that then you have to do something probably more invasive, put in a tube, or now do a self-bag mask ventilation. So I'll just go to the case updates of the 57-year-old man.
Yes, before we get that, Irene, let me just add before we forget that there is a chart, I think, in the Learning Resource Center you can get, and we encourage all participants, where possible, to get a printout and paste it on where they all work as a quick reminder of the correct device to use. It's a quick reminder. You just look at it and you know what you need to use. Thank you.
Yeah, thank you, Dr. Datti. I think that's very important. We've tried to do that in my unit. If you can't even print out, if you don't have a printer, you can write it out, and get it typed. If you can't print it out, write it out and put it on your notice board there in the unit. It comes in very handy. Thank you very much, Dr. Datti. So I'll go on to the case update. You continue to perform a history and physical exam and discover the following: past medical history of polio, type 2 DM, and HIV. He had an inguinal hernia repair in 1988. He's on some medication. He's antiretroviral, long-acting insulin, and preprandial, that's pre-meal, sliding scale insulin for his type 2 diabetes. On his family history profile, his mother is deceased with a history of hypertension and diabetes. His father is deceased and a history of emphysema. He has one younger sister who is healthy. He has 2 children that are healthy. Social history-wise, he works in the construction sector. He takes 2 alcoholic drinks 3 times a week. He does not smoke and does not use illicit drugs. Review of systems shows a left facial droop from childhood polio. Otherwise, there's negative other than history of presenting illness. Now you have a nursing student with you and who asks, what did you plug the oxygen into? Where does the oxygen come from? That's a nice question. Now, the next question we have is, what are the different types of oxygen supply? What does your facility use? This would be nice to have answers in the chat box. Please, could you put up our answers? The types of oxygen supply and what your facility uses as a source of oxygen supply. Just have a minute or two. Yes, what type of oxygen supply does your facility use? I think that's enough. Let's keep the answers coming. We could scroll down a bit, so probably give them the options to say 1, 2, 3, 4. So top left will be 1, top right 2, bottom left 3, bottom right 4. Top left 1, top right 2, bottom left 3, bottom right 4. Thank you. So we've gotten some responses. Oxygen from pipeline and concentrator. Oxygen concentrator and from cylinders. Okay, so we have someone who so we've got concentrator, pipeline, oxygen bank there, which is piped, the bottom 4. Okay, we have quite a lot of responses. More of 1, 2, and 4. Thank you very much. 1, 2, 3. Thank you very much. Oh, someone has liquid oxygen system. That's number 3. So 1, 2, 3, 4. That's good. Okay. Dr. Datti, can I continue? Okay. So can we continue, please? Hello, can?
Yes.
Okay.
Thank you
Okay,
very
yeah.
much.
Okay.
Yeah. Okay.
Okay, he's clicked.
So excellent responses.
Yes.
And you
This is
can
a
look,
lot.
there are available resources. I mean, WHO, you have oxygen sources and distribution for COVID-19 treatment centers. You know, it's quite recent. You need to know about all that. Even maintenance of your oxygen sources, how to maintain plants, and so on. We know it is scarce in Africa and other low, middle, and income countries. But the essence of all this session is to know how to use the oxygen judiciously. It's good to know your supply, how much you have, and then with the devices that you have, then you should know how to use the oxygen for optimum response or management of your patient. Okay, so all these things are available on the Learning Resource Center. Can we go back to the main case discussion?
Okay.
All right, let's scroll down. Yeah. So these are the change, the practice change we expect all of us to do based on what we learn here or from the Learning Resource Center on this topic. You should try to look at your facility, like I was trying to say, to understand the oxygen supply that you have, and the options you have available, so that, like you said, you all have. If you don't have enough, then you should be encouraged to use the devices that you use low flow to achieve what you want to achieve. And remember always to set your target. Don't just say, if you say 94, you want it 94% and above, that's okay, before you escalate. Then you should list the number of each of the following oxygen cylinders, oxygen concentrators that you have. Then you should note if your facility uses pipeline gases. And you should also understand who maintains the oxygen supply systems. There is a way you maintain all these oxygen cylinders for safety and so on. You have the risk of fire and explosion. For example, I remember well the regulator, you cannot use oil. You will see that use no oil and things like that. So you should be very careful. You have protocols to deal with that. Then you should survey your facility to understand oxygen delivery devices available. This we have mentioned earlier. And note if your facility has each of the following, that is the nasal prongs, simple mask, Venturi mask, and mask with a reserve bag, so that you will know when to escalate. If you don't have, say, the simple mask, then you will be forced to move from nasal prongs to Venturi mask. You should understand who orders, maintains, and sterilizes medical equipment for you. I'm sure all of us, we have local protocols for disinfection and sterilization for reuse of these devices. We don't have enough. Some of them are single use, but we concede or we confess that yes, we have to reuse some of them until we cannot use them any longer. But the key thing is that we need to disinfect them according to local protocols. Then you should try to save on your phone or download and print Lightbox triage tool. It's a very good tool to assist in managing hypoxic patients, which we encourage that you can write if you don't have facilities to print and paste on the walls in units where you work. And then you should post the Lightbox triage tool in relevant patient care areas. This is what I just said: emergency care, ICU, wards, and so on. So let's move to the case update of the patient.
Sorry, Dr. Datti, please, can I just add one thing based on the change of practice? I think it's done in some centers, so it's things we can learn is at the beginning of your shift, it's nice to find out from the head of the oxygen plant, what is the status of oxygen in the hospital? What number of patients do you have either in the ICU or the A&E that require oxygen? Then I found out the use of oxygen concentrators come a lot very handy because we're taking from atmospheric air. Now we are worried because we don't want them working continuously because of its motor function. So I say, use the oxygen concentrators. When we have power outage, which happens, there's a cylinder there. So we don't exhaust the cylinder a lot, especially we know with COVID, the demand for oxygen has been a lot. So we're able to maximize this, the amount you have in your cylinder, while using more of the concentrators, as long as patient is not intubated. So that's just something that has helped us in judicious use of oxygen. Thank you.
Thank you very much, Irene. Now back to our case. Suddenly the pulse oximeter on this patient starts to alarm. You know, there is an alarm that sounds when it is out of range, or you set it to give you an alarm when saturation is at a certain level. So you have a student with you who now asks, what is wrong with the patient? So can you type in the chat box, what can make pulse oximeter alarm? Let me know what, because you've been using pulse oximeter before we click. Type quickly 1 minute into the chat box. What can make a pulse oximeter alarm? What do you expect to see when you go to look at it? Type in what you see in your practice. Those of you using the pulse oximeter in the emergency room, the ICU, the ward, the emergency children's ward. Okay, if the oxygen saturation is below 90%, when the SpO2 is below normal range, excellent. Low SpO2. Movement, drop in oxygen saturation, use of diatemy, drop in pulse rate, yes, there is some disruption, excellent. Low battery, yeah, that is true. That is when you know you want to recharge. If it is the pulse oximeter that uses battery, you need to change the battery or you need to plug in. Okay, when there is interference that is not firmly attached, yes, and SpO2 is low. Excellent answer. So let's click on what we see to compare with our answers. Yeah. So when you go to this Learning Resource Center, you see this, there's a video, let's watch it, you'll find the answer. Yeah. Sorry, there is no audio.
Okay, I'll share with the audio.
Mm-hmm. So Dr. Suleiman, after the video, you can proceed to discuss this stage.
Okay, sir.
All right.
Can you
Thank you.
interpret this SpO2 tracing? What is the heart rate? What is the SpO2?
Okay. We should take note of the figures displayed there and also the pattern of the SpO2 platysmograph. So please, I want people to quickly write some of the observations, vis-a-vis the saturation, the heart rate, and the plethysmograph. What do you think is happening? Maybe for a minute or two, we expect your answers to come in. Hello, please, am I audible?
Yes, we can hear you.
Okay, sir. So we are awaiting answers from participants. We've all seen the value there of the saturation, the heart rate, and the plethysmograph. So what do you think is happening there? Okay. Let me see. Answers have not started coming in. Anything there? What do you think is the most likely problem for this particular display that we are seeing? Okay, for this particular display that we are seeing, how do you interpret? Well, sir, should we just go ahead and continue the discussion? I've not seen
Yes,
any
we should
coming.
go ahead, but we should remind them that what the answers they gave earlier on the possible causes of the alarm, now they've come to look at the monitor. And see this is what is being displayed. So we just want to know how to interpret this figure. And that is all. So maybe that will help them understand. So you can proceed.
Okay, sir. Before we click on the frequently answered question, please let's go back to the display. There are some key things that I want to bring out. If you look at the display, move up. Yes. You see, the saturation is 83%, and the pulse rate is 55. So it's showing both hypoxemia and bradycardia. However, we should always interpret our pulse oximetry for the type of pulse oximeter that has a plethysmograph, in view of the plethysmograph. If you see the pattern of the plethysmograph, it's not regular. It's not regular. So the commonest cause of this is usually poor contact. Poor contact is the commonest cause of this kind of problem. And as we all know, once you have an abnormal sound from your pulse oximeter, the first thing you do is to check whether your pulse oximeter is properly placed before you can really say what is showing is valid or not. Please, let's click on the frequently asked question. Say, how will you respond to this student? How will you respond to the patient? Okay, this is a video. Okay, this is a pulse oximetry training manual. I think we should all go and take a look at it and probably download it, and we can as well use it to train some of our staffs in our various facilities, because you'll be surprised to find out that apart from the anesthetist and the ICU personnel, there are a lot of people that cannot actually interpret our pulse oximetry. Please, let's go back. The document is too much. We can follow it bit by bit. So people should go and check it back later. So what this thing is trying to tell us is, as soon as you have a beep or an alarm, the first thing you should do is to check your pulse oximeter whether it's properly placed. Okay, because that is the commonest cause of having a wrong reading. Okay, of course, when you check and it's placed, then and is properly placed and it's reading and the waveform is good, because any pulse oximeter reading without a corresponding, regular waveform, the reading is not valid. So these are some pitfalls that we need to know when using pulse oximetry. So the response is, first, you check if the pulse oximeter is properly placed. If it's properly placed, is the plethysmograph, regular? If it's regular, from the plethysmograph, you can have a crude knowledge of your heart rate. Then is it matching with what is being displayed? Okay, because at times your plethysmograph will be fast. You know that this heart rate is probably more than 100 or around 100, and then it will be showing you bradycardia, maybe a heart rate of 50. So once it doesn't match with the waveform, know that your reading is not valid. But when you confirm that it's actual hypoxemia, then the next thing you do, depending on the scenario, and you try to find out what is the cause of the hypoxemia. At the same time, you commence oxygen therapy as earlier stated, following the steps. You start with the least invasive and graduate to the most invasive as required. Okay, so let's move up.
Now, Suleiman, permit me to add something to what you just said. If you go back to the questions, there are two questions there. What you say, how will you respond to this student? How will you respond to the patient? The questions are together and you do them at the same time. If you are a consultant, whether a respiratory physician or a consultant anesthetist or an intensivist, you have residents with you, or you are a senior nurse in the emergency room, you have a student nurse with you. What you do, what Dr. Suleiman mentioned, then you try to carry the student along, say, let us look at this, and then he's watching, and you can even add the student, check the pulse. Because one of the things that can happen there, the hemodynamics, blood pressure may be low, the patient is, or the probe is out of place, and then our patient may be hypothermic, and so on. So you'll be able to do this together. That is one way, one of the best way to respond with the student is there for learning. Thank you.
Thank you, sir. So please, let's move up. Okay, so among the practice change action that we may want to implement in our various facilities is we should be able to know those factors that affect the accuracy of pulse oximetry reading. As we've mentioned, contact is one. Dr. Datti has mentioned some, like the hemodynamics, which is actually one of the problems when you need pulse oximeter the most in patients who are hemodynamically unstable. Usually, that's when it's malfunctions. So patients with low BP, patients with arrhythmias, hypothermic patients, anything that will cause extreme vessel constriction, all this will affect your reading. So you need to know that. Also, patients with nail varnishes, like our ladies that usually put nail varnish on their nails, that could as well affect your pulse oximeter reading. Also, appropriate size of pulse oximeter, because by the time you are using an adult pulse oximeter on pediatrics, which in some centers we likely do that due to maybe unavailability of appropriate size probe. That may as well affect pulse oximeter reading. So we should try to know all this. Also, the ambient light at times may also interfere, and some of the things have also been mentioned, like diatemy, noise, movement, all this. So we should try to know that. And then also try to recognize the latency, because the relevance of this clinically is when you place a pulse oximeter probe, you should allow it for that time of latency for it to read and send the signal. Okay, because you may be eager to just see the reading immediately you put the pulse oximeter, and when that is not happening, you may think maybe the pulse oximeter is faulty or something. However, that's not true. It's just that you have not allowed the pulse oximeter to undergo its latent period, which is approximately about 30 to 40 seconds or so. So this is very important, and we should know all this. The reason why we are saying all this, because not knowing this may make you to, give interventions that are not necessary, or at times which may even be harmful to the patient. So having this knowledge make you to give the appropriate intervention and make the right decision at the right time. The next item is a case update, and it's saying that the pulse oximeter probe had fallen off the patient's finger. You had your students repositioning the probe, and now SpO2 reads 95%. So we've already mentioned that, considering the plethysmograph and the readings, most likely the pulse oximeter is not properly placed. So this has confirmed what we really suspected. The next frequently asked question, say, how do you properly care for pulse oximeter, and how do you clean them between uses? The care for pulse oximeter becomes important because, they are used on several patients. It's not like each patient has his own pulse oximeter. And secondly, it's not a disposable equipment, even though we know we may have some disposable probes. However, the most likely thing to happen is that you use same pulse oximeter, especially on the multi-parameter monitor on several patients. Therefore, in order to prevent disease transmission from one patient to the other, and also prolong, the lifespan of the equipment of the pulse oximeter, you need to, take care of it very well and know how to maintain it. After every usage, it's expected that you clean the pulse oximeter. Usually, you may use 70% alcohol. However, you can just spray it on a tissue paper or a cotton wool or a gauze, not to the level that it will be dripping and it may, the liquid may get into the equipment itself and even soak something. No, just enough to moisten the gauze or the cotton wool that you are using, and then you clean. Also.
Yeah, so sorry, Suleiman, maybe I have to, because we have a few minutes to go, the time. I think it's important to click on whatever resources we have here to help our participants, remind them of what they used to do and change. Yeah, let's watch and see.
Sarah, please, can you share the video?
Between patients, it is essential that you gently clean the probe and cord with medical alcohol. Small amounts of 70% alcohol-based hand rub will also work, but should be applied sparingly. It's important to keep the LED and photodetector clean. Please also remember to wash your hands, following proper protocol between patients. The oximeter should be wiped down regularly, using common detergent and non-corrosive disinfectant, such as those used in hospitals. Be aware that many kinds of detergents must be diluted prior to use. The oximeter case and screen can be wiped with a lint-free soft cloth or a sponge moistened in detergent. While cleaning the oximeter, be careful not to spill liquid onto the instrument and do not allow any liquid to spill inside the oximeter. When wiping the side panel of the oximeter, be especially careful to keep liquid away from the cable and the outlet.
Well, so we've all watched the video. Basically, it's what we're discussing on the reasons why you need to take care of your pulse oximeter, clean it, and how to do that. We've all watched the video, and I think even though despite our tight schedules and everything, I don't think it's something difficult that we cannot do. It's very important, especially in this era of so many infectious diseases. COVID is there, hepatitis, HIV, so many things. So please, we should try as much as possible to observe these cleaning protocols. It's very important. Not just transmitting disease between patients, also between you and the patients.
Yeah, thank you very much, Suleiman, for this valuable input. We're approaching the time is almost 90 minutes since we started. One thing I want to add is that the cables, the way, don't squeeze them after use. You should try to, in a circular fashion, you roll them and keep them safe, so that you can prolong your the use of your equipment, the function of your equipment. So the practice change objectives here, I want to go over them quickly. This session, we're able to understand how to use pulse oximeter during the COVID-19 pandemic, understand and recognize pulse oximeter latency, and then how much oxygen in terms of percentage, FiO2, that we should deliver, and then the use of the live box triage tool to help us choose which device is more appropriate. And then you assess your facility on non-invasive oxygen delivery devices. You have your oxygen supply and so on. And then finally, how to clean and maintain your pulse oximeter devices. All these are available on the live learning resource center. Anytime you log in, you can download, print some of them, and go over them. Thank you.
Thank you, sir.
Over to you, Kevin.
Okay, thank you. Thank you so much, Dr. Datti, and all the panelists, Dr. Suleiman, Dr. Irene, and Dr. Salim for leading us through the session. And also thank you to the participants for giving your time until the session. Now we are about to do a session wrap up. So I would like to remind everyone to visit the Learning Resource Center, LRC, for the presentation, slides, and the recordings that we have been doing this session. The site also includes many additional resources, quizzes, case exercises, and videos. And that is the link to the Learning Resource Center. Links to the recording, LRC, and the feedback survey will also be shared after the session by email and in the WhatsApp group. For those of you who have not yet joined the WhatsApp group, you can scan this QR code here, or you can message assist at this number here. So after saying that, I would like to thank you all and remind you, please join on the session 3, which is going to be held on the April 8th, and we are going to be discussing on the frequently asked questions and right round and the round table. So if you have any questions, send your questions through this email below. And thank you so much for joining. See you in the other session.
Thank you for all the support, and thank you to all the participants.
Thank you. Bye.